What about radiation oncology? Radiation oncology and radiation therapy for breast cancer is generally done after we've done surgery. There are times that, in fact, we can use radiation therapy on an urgent or emergent sort of basis. And I'm sure this varies around the world, but I have seen fungating breast cancers where the patients come in with bleeding and they are basically inoperable. And we've got extensive local regional disease, or we've got symptomatic metastatic disease from bone or central nervous system. Then we can consider palliative hypo-fractionated regimens to get, as an example of the fungating breast cancer, get the active bleeding under control. Fortunately, in the United States, those kind of cases are rare. Around the world, that may not necessarily be the situation. And so radiation therapy can be done as a hypofractionated regimen in the United States, Western Europe, elsewhere. Around the developing world in the United States, we have more cobalt-based radiation therapy that can be used as well. Or if we've got some progression of disease during neoadjuvant chemo, there may be circumstances where a hypofractionated regimen can be considered. Now, here's again a very, very busy slide that I would recommend that you go to the manuscripts to see whether these would have applicability to your particular circumstances. But here's a good example. Again, we've broken this down into B1, B2, and B3. I'm going to focus primarily on the B1 category. So now we've got an inflammatory breast cancer. It's completed its neoadjuvant chemotherapy, and the mastectomy has been done promptly, as I indicated earlier, the appropriate nodal procedure done. And we know that part of the treatment of this horrendous disease, inflammatory breast cancer, or many of the locally advanced breast cancers, really requires a post-operative, post-mastectomy radiation therapy. So not only would we consider it, but depending on resources and the state of the pandemic, wherever you are, we ought to proceed ahead with post-mastectomy radiation therapy forthwith. What about patients who are node positive with triple negative HER2 neu positive disease, and their status post breast conserving treatment or mastectomy? Again, we don't want to be waiting around. So we would move ahead with whole breast radiation therapy, including axillary radiation therapy, or if they've had a mastectomy, post-mastectomy radiation therapy, including the appropriate axillary targets. What about post-mastectomy patients with 4 or more positive lymph nodes found at the time of sentinel node biopsy or axillary dissection? The literature is quite clear that these patients benefit from adjuvant radiation therapy. And so we would again proceed ahead with post-mastectomy radiation therapy with the appropriate axillary targets. And or we've got residual lymph nodes that are still positive after neoadjuvant chemotherapy. We again know the value of whole breast radiation therapy or post-mastectomy radiation therapy. These other categories are still in the B. I'm not going to go through. Here's a good example. Node negative, triple negative breast cancer, HER2 neu. They've had breast conserving therapy we're not going to want to wait 6 or 12 weeks for patients like this. We want to consider starting their whole breast radiation therapy within the 3 to 4 weeks normal recovery period, but not wait certainly out to 12 weeks, or if we've got margin issues or younger patients, etc. Again, these tables that I'm showing you are available in the manuscript that I've already shown. Under the C category for radiation oncology, then initiate endocrine therapy if they're estrogen receptor positive, and defer radiation therapy until the pandemic is over, or we're certainly through the crisis phase of it. And then for patients who are greater than 65 years of age with early stage node negative, estrogen receptor positive, HER2 negative, who are taking adjuvant endocrine therapy after breast conserving treatment, we may be able to admit radiation therapy totally, or certainly defer until the pandemic peak is over. The exception to this is, in category C, is estrogen receptor negative DCIS with positive margins. We would probably flip them back to priority B3.